Welcome everyone. My name is Flóra and I'd like to present to you my PhD topic, which is complex therapy for children with cleft lip and palate. But before I dive into my topic, let me introduce myself a bit further. I'm a first-year PhD student and the second-year orthodontist resident at the Department of Pediatric Dentistry and Orthodontics. Working in this clinic has given me the great opportunity to work with children with different anomalies, and it actually gave me the urge to understand more the complexity of the cleft's origin and care, and I like to achieve that through researching different etiology factors and treatment possibilities. As I mentioned before, I'm looking into the complex therapies, so I'm not just looking at after birth, but also before birth, meaning I'm looking into the whys and the hows as well. This leads me to my first topic, which is a systematic review and a meta-analysis about investigating the effectiveness of presurgical therapy possibilities for unilateral cleft lip and palate in infants. As I'm aware, we're all working in healthcare, but even if we weren't, I'm sure all what we wanted for our children is to have a very happy and healthy life, particularly with their childhood, because obviously it should be carefree. But little do we know that cleft lip and palate is one of the most common congenital anomalies affecting the craniofacial region. Out of 800 babies, one is born with this anomaly. The etiology itself is multifactorial. It depends on the combination of environmental and genetic factors, and the prevalence itself differs in races and countries as well. The malformation itself happens in the first trimester of the pregnancy, where the palatal shell fusion gets disturbed for some reason. But why am I researching this topic? Why is it important? If anyone's born with a cleft, they have an actual opening between the mouth and the nose, meaning their basic life function are completely impaired. They're not able to breastfeed properly, they can't breathe properly. Later on, it's going to cause speaking and hearing problems. Therefore, it can be malnutrition ways, and also their development is compromised. So the cleft doesn't get closed until the age of 1, so this is where our part comes in as orthodontists. We can offer them a therapy option called a PNOM, which is a presurgical nasoalveolar molding. We meet them in the first month of their life. We take impressions, we make moldings of that, and then you can see on the upper right pictures, we create acrylic plates. We can place these plates into the mouth with a removable appliance glue, and we can also use kinesiotape for the lips and a nasal stent for the nose, function aesthetic reasons. They have to keep it in for 24 hours. They can only take it out once a day to clean it and change the tape. We see them every 2 to 3 weeks. We have follow-ups with them, and we can actually fabricate the acrylic, so we can guide the bone to grow in a different way. Now that they're wearing this acrylic plate, the gap between the nose and the mouth is closed, meaning life functions are given back to them. They can probably breastfeed, they can breathe as well. It's a lot easier for the parents as well, beside a lot of work. Now that I explained it to you, I'm guessing you're saying, why do I have to prove that this is great since it's amazing? But unfortunately, the gold standard is very controversial. We don't have an actual guideline on how to treat them. Also, this therapy is not available in every clinic. This leads me to my clinical question, which is how efficient is PNOM treatment in UCLP patients? Our population is infants with UCLP. Our intervention group is the PNOM treatment group. Our comparator is the one that doesn't get the treatment, and we're looking into the cleft shrinkage. Our hypothesis is there's no difference in efficacy between the PNOM and the NOTMAN treatment group in the UCLP. And our clinical and research implication is using PNOM treatment leads to guided alveolar growth that results in cleft shrinkage. I've conducted my systematic research in 3 different databases, and as you can see, I only got 500 articles. It's a very small amount of articles since it's not a widely researched topic. So we got down to 8 articles until now. I've explained to you the functional benefits of this acrylic plate, and now I'm going to try to explain to you the measurement side as well. In the right picture, you can see a normal plate, and in the left, you can see an actual cleft palate. It doesn't get closed until the age of 1, as I explained it before, so you can see the bigger the gap, the longer the distance the surgeon has to close. We all know from normal surgery that it can lead to postoperative complications and many difficulties as well, so our aim is, if we can in any ways, make sure that this cleft gets shorter and we can close it somehow so the operation is easier in that way. How we can achieve that. As I mentioned before, we're using this PNOM protocol where we can actually fabricate the acrylic so we can guide the bone to grow into a manipulated way. But how do I prove that this is efficient, actually? We pick out 3 different points in the maxilla, and we measure them right before treatment, which is just after the birth, and after the treatment, which is right before the operation. Obviously, the plate has different effects on the maxilla points, but let me show how. First, we're looking into the anterior cleft with shrinkage. This is the part that we're expecting to grow the most, since this is the one that can be manipulated the most. We're looking into millimeters. Unfortunately, we don't have a guideline that says they should be 5 millimeter less or 4 millimeter less. We only can say that whether if it gets smaller, we're already very happy with it. For this, we used 3 different articles, which were all randomized control studies with a number of 120 babies. The heterogeneity itself was 99%, which is pretty high, but that can be explained with the fact that they use same treatment, but kind of different protocols and follow-up times, follow checkup times. And we looked into the 2 different groups, which was the treatment group and the non-treatment group, and looked into the change of how much the measurements changed. That led us to our mean difference, which is 6.62 millimeters of change. This obviously favors the PNUM group, which means that using this plate actually helped to close the gap a bit. Moving on to an intercanine region width shrinkage, which is basically the future canine points, where the position will be. And here we're actually expecting it to grow, as the babies are growing, it to grow a bit wider. So what we're looking in here is whether it's to stay the same or if it shrinks, we're very happy with the results. As you can see, the heterogeneity itself was smaller due to the fact that this is changing less. And here as well, we had an 0.28 millimeter shrinkage, which is great since it didn't get wider, and it favors also the PNUM group. We moved to our posterior cleft with shrinkage, which was the last point that we checked. This one was the one that we're expecting to change the least. So same goes here. If it doesn't get wider or if shrinkage, we're also very happy with it. Heterogeneity itself was very slow here. And the mean difference was 0.21 millimeters, so it actually shrank as well, which means it also favors the PNUM group. Although none of the actual data was statistically relevant clinically, all of this actually prove that we're moving into the right direction this way. The strength and the limitations of our studies. We all use randomized control studies. A large sample size was used from different countries and races, and they used the same inclusion and exclusion criteria, and the limitations were that they used different intimate orthopedic protocols as seen in the heterogeneity before, and we have a very small number of articles, unfortunately. And because of our preliminary results, we can only have just a preliminary conclusion as well. Our practice indication would be to actually have a broader and general inspection for this, so more clinic would actually use it after we have our actual results. And the research implication is that we need more RCTs and a guideline, because if we have a guideline, we can have a homogeneous way of actually treating them, and maybe we can have the less heterogeneity this way. I've explained the hows now, but I need to explain the whys as well. This leads me to my second project, which is a retrospective case control study on seasonality and birth month of patients born with orofacial cleft between 1960 and 2023 in Hungary. As we talked about before, orofacial cleft is a very multifactorial anomaly. It affects, obviously, we know some of the results of the habits, the genetics, but we know very little about the environmental factors. So every study that we looked into either offering a conflicting conclusion or there are more studies are required. This is what they're putting out. So before diving into more environmental factors, we have to see if there's a pattern or not between the birth. As I mentioned before, the prevalence of the orofacial cleft differs in races and countries. So many population, Australia, China looked into this issue, but we're lacking a Hungarian one. But luckily, we have the Hungarian Congenital Abnormality Registry, which is a major database that has including all this data that you can see on the slide. And from this, we can see whether there is a pattern throughout these years with the birth rates. And from there, we can actually move on to looking into etiology factors. This leads me to my clinical question, which is there a monthly birth rate pattern in patients born with orofacial cleft? The population would be babies born with cleft lip, cleft palate. Our exposure would be month, and outcome is different birth rate. Our hypothesis, there is no seasonality in the birth rate for babies born with orofacial cleft, and the clinical research implication is that finding seasonality in orofacial cleft can give a solid basis for further research of etiology factors. To summarize my project, working with these babies has shown that they have very difficult life to start with. Also, the parents need a lot of patience and empathy to work with them. So in any ways we can help them, either knowing the hows and the whys. I think it's very important to research it and put it into good clinical use so we can help them through this period of time. I'd like to thank you for your attention with the quote, "The greatest enemy of knowledge is not ignorance, it's the illusion of knowledge." Thank you very much.
Okay, thank you, Flóra. Why do you choose only to check the birth date? I'm just thinking about this. How are you going to deal with all the possible confounding factors? since this is just a minor etiological factor, and how are you going to deal with all the other that could actually affect these results?
Thank you for your question. First, the idea was to see, we actually did some preliminary research, and we've seen that if you see, for instance, that every year January is the month that there's a lot of babies born with cleft, and for instance, March there's basically like 0, then you know that it has something to do, if we're looking into environmental factors and we're leaving out all the cofactors, so genetics and anything that has to do with habits, so drugs and alcohol and smoking. So what we do, if we see, okay, this is January, and then we can count back, it has to happen in the first 3 months of the pregnancy, so then we can look into those 3 months and see what was the weather like. We see UV, we can see the vitamin D. There's so much to look into, but first we have to have a clear picture about it, what to look into realistically. So that's why
you plan to exclude other confounding factors, for example, smoking or any other of these habits? Yes. Okay.
For now we are.
Very nice presentation.
Thank you.
My question is, what are the contraindications of the PNAM treatment?
Thank you for your question. It can be one-way allergies. So if they have any allergies to acrylic or the glue that we're using, either the tapes or, for instance, the stand that we're using for the nose, this is just a general. Obviously, if there's any general illness that can lead to hospitalization that we're not doing. Also, if the parents are not working with us properly, so they're not actually using the treatment, they're not retaping, they're not putting back the plates, then obviously it's an exposure to illness to bring the babies into the hospital every 2 to 3 weeks. So that's also one of the contraindications. Thank you.
I have a question about, you said that every 3 weeks there is a checkup, and you able to modify the plates. And how exactly does it work?
Thank you for your question. So what we do is we take out obviously the plates, we clean them, and then it depends if we're using UCLP, so it's a unilateral or a bilateral, we change it differently. But what you want to do is, obviously it has the same way as you would see in the maxilla. So the compounding factor is that the one of the 2 alveolar bone that's closer to each other, you take out the acrylic, but you leave it everywhere else. So when it tries to grow, it will grow into the way that you want it to grow. If it's bilateral, then you take out just before the premaxilla, you take it behind of it, so you can actually tape it and kind of like protrude the maxilla better and retrude it as well.
Thank you so much.
So Flóra, hi.
Hello.
So here's a difficult question for you.
Yes.
And this is for everybody else.
Great.
So in the implications for research, you are making the statement that more randomized controlled trials are needed. Why? Based on what?
Based on the small amount of articles that we're using.
But they are randomized controlled trials. Theoretically, they are powered enough to answer the research question. This is a learning moment. If you're recommending that further randomized controlled trials should be made, you have to justify why. It's not until we reach statistical significance.
Okay.
There is a reason behind making such recommendations. So be very careful in the manuscript writing as well.
Okay. Thank you so much.
Is there any other treatment for cleft shrinkage besides PNAM?
Not preoperatively, no.
And why do you think there are not many studies done since 2000, basically? So since 2000, you only had 3 studies. Why do you think that happens?
Well, there's more that we didn't include that you didn't see on the, because we have 8 articles, you only see 3 that's included. And it is a good question. I think somehow they're either moving to the 3D printed version, so that's what we're trying to do. Or obviously it's very difficult to put this amount of children and see one of them is not getting treated. So if the clinic believes in the idea that it has to be treated, then how do you pick the kids not to be treated? So I think it's also an ethical issue that we're dealing here.
And also probably, is this widely done, usually in the clinical practice, the use of PNAM?
It's done in one place in Hungary, which is Budapest for us. Not many places, some other might do it, but it's not like widely done. This is what we want to have a general idea about it so everyone can do it, not just like one clinic and everybody comes from the country there.